This video is based on the case of Elaine Bromley. Many details of this case are not known. The depiction of unknown events has been based on the best estimate of expert clinicians. The scenario portrayed thus represents only one possible interpretation of the reported events and approximate timeline of the case. It is not intended to depict the specific actions of particular individuals. Elaine Bromley presented for endoscopic sinus surgery and septoplasty in March of 2005. The level of staffing and facilities at the clinic she attended were considered to be of a high standard, and both the anaesthetists and the surgeon involved in her case regarded as experienced, diligent and respected clinicians. The primary anaesthetist performed a thorough preoperative assessment on the patient prior to surgery. The only finding of note in her history was of congenitally fused cervical vertebrae.
Do those cause you any problems with limitations in your neck movements?
Only slightly when
On physical examination, a slight restriction in rotational neck movement was noted, but there was little limitation of neck flexion or extension. There was nothing to suggest that Mrs. Bromley would pose a particular problem with regard to airway management during anaesthesia. The anaesthetic plan was to perform a general anaesthetic using isoflurane and nitrous oxide, along with a remifentanil infusion at 0.3 mics per kilo per minute. The airway was to be maintained with a flexible laryngeal mask.
I'm just going to start making you feel a bit lightheaded in a minute. Are you feeling comfortable there?
Yes, thank you.
Good. Okay.
Okay, Helen, so are you happy with a size 4 reinforced LMA?
Yes. And can we have a size 3 reinforced ready, just in case I need a different size?
Yep, ready to go.
Suction ready to go?
Yes, yep.
Vital signs are within normal limits?
You happy with that much air in the cup?
Yes, that looks good. Just want to check we've got face masks and also intubating equipment ready. Give me that. You're just going to feel something cold going up your arm and you'll start to feel sleepy in a second. Okay, we're going to be here all the time looking after you really well. 200 of Propofol's gone in. Can you open your eyes for me? Just hold the jaw down. Oh, it's hard to... She's tight. I think you're going to need some more Propofol. Can I get you to draw up some more Propofol for me?
How much do you want, Helen?
Just 50 milligrams, 5 mils, please. Sats are still holding up. Still not getting this in.
So I'll drop 10, but just give 50.
Thank you, yes.
Do you want me to give it now?
Yep.
So that's 50 is given.
Just to help me hold it open. No, it's still pretty tight. Let's see if I can try it out to the side.
Do you want to try the smaller one?
Yeah, that might be an idea. Yeah, thank you. Try again with it, holding a jaw down. Still difficult to get in. I'll try it upside down.
Sats are falling.
Okay, let's go face mask ventilation.
The bag, please.
Thank you. Get a flush, please. Yep. Oral airway, please. Hold it, jaw down again for me, still tight. Flush, please. Got no rise and fall of the chest. No. Can I get you to get me a larger oral airway? Yeah, thank you. Other one. Do two hands.
Do 2 hands?
Yeah. An oxygen flush.
Flushing.
Yeah, no CO2. Not ventilating it. We'll need to intubate it. Can I get you to get the equipment ready and I'll get up some sucks on it?
Sarah, can you get some help in here?
Sucks has gone in. Patient's really bradycardic. Draw up some atropine. Give a 0.6 of atropine. 0.6 of atropine going in now.
Circulating now.
Good. Circulations have ceased. Can I have the laryngoscope, please?
What can I do for you?
Unanticipated difficult airway, and I've already had a guy trying to get a laryngeal mask and also face mask ventilated unsuccessfully. She's had 100 of sucks and she's also had. Can I get you to give me some laryngeal pressure? I can't get a good view. It's grade 4. Can you try and move it a little bit? Yeah, lift the head might help as well. No, that's not helping. Can you lift it up a bit more?
She's still bradycardic.
No, I'm not seeing, that's not making things better. Lift her head up more. I think we're going to have to go for a larger.
trolley? We've got the tracheostomy kit on it.
Larger
Size 4
laryngoscope,
Mac?
yeah, size 4 Mac. Okay, no, I'm afraid.
I'll call RCA and see if there's a bed.
Here, I need some more laryngeal pressure. Over to the right.
Yep.
Can you lift the head up more? I'm still getting a grade 4 view. No, that's
Do you want to try the bougie?
more lifting on the head? No,
Bougie?
no. I can't see the I can't even see the epiglottis, so that's not going to help. I'm going to come out. I need a McCoy blade.
You've got airway trolleys on its way.
I'll need face mask back again.
Difficult
airway.
Anything I can do?
Look, we're just going to face mask ventilator again. No,
Difficult airway
no,
McCoy's available.
CO2, yeah, well, I'll have that straight away.
Do you want a 3 or a 4
I'll
blade?
take a 4.
Tracheostomy set's available.
Now, I'll get you to do laryngeal. Can you, just move the laryngeal pressure to the right. Lift your head up more. Lift it. I need the head lifted. Perhaps if you do the laryngeal, and I'll get. Yeah. You can lift your head up.
How do you want it?
Yeah, lift it up. Lift up as much as you can. Much as you can. No, I'm still not seeing anything. It's still a grade 4 view. No, it's not helping. I'm going to have to come out. Yeah, I will need some suction. Yeah. We'll go back to bag and mask. Can I have the oral airway again? I'm going to put the head down again. Okay.
You want to help?
Yeah, just leave it here like that. No, that's fine.
Do you want me to have a look?
Yeah, you have a look.
Right. Can I get a Mac 4?
Yep. I'll do some pressure.
Yep.
Yep.
Just lift the head a bit higher again. Yep.
Yep.
Great. Just push the hand across that way.
Right, okay.
Beds available in ICU.
Give me the straight blade. I think we should go back to mask ventilation.
Okay.
Do you want me to hold the hook still?
Make it go.
Okay.
Can I get that anyway,
That's a
please?
little bit.
That's it.
No problem. Turn the head a little bit. Okay, a bit more pressure.
Yeah.
Yep. Lift the head a bit higher for me. That's good. Down again, back down again. That's not helping. Too far.
Is it?
Down. I can't see anything. I think we should go back to face mask. I think we need a fibre optic scope. Fibre optic scope, where's the scope?
Jen, can you open up the intubating scope?
Yep.
There you go.
Can you get me that blanket, please?
Can you do the scope?
Talk over here. I'll get the
Okay.
I'll just put on a little here.
What size tube do you want?
7.
Another
Just
size
the
7.
rest of the intubating elementary.
And
Yeah.
can I have a straight blade? Straight, yeah.
Fit it on.
I might need you to do some pressure
Alright.
in a minute.
Yeah.
I've got the scope.
Okay. Do you want oxygen or suction on that?
Oxygen.
Which one over the head?
Just leave it as it is. Open the mouth one. That's it. That one. There's blood everywhere.
You want suction?
Yes, yeah, suction. Change that.
In front.
I can't see anything. No, this is no good. There's blood everywhere. I can't see anything. Straight blade, please. That Miller blade. Yep.
You want suction?
Yep. Step them out. Sucker. Okay, just turn the head a little bit. A bit more pressure.
Do you want me to lift the head?
Yep. Yeah, it's better. No. Sucker. I still can't see anything.
Oh, we haven't got your rigid scope.
That's right. Stick me as a normal.
Can you hold it?
No. Yeah. Okay. So I'm see the ebb glass. Got a
Bougie?
bougie there.
Yeah, we've got a tube
Just
here.
put a tube down.
Got it.
Okay. So bougie out.
Bougie out.
Yep.
Here in the car.
Yep. Just careful.
But there's no CO2.
It's not in. Let's pull it out.
Can we try that intubating laryngeal mask and we'll try and intubate through that?
Okay. So it's 4, yeah.
How's the head?
Yeah, that's good. Cover circuit. We've got CO2 this time.
Not yet. There's a little bit.
There.
A little bit. Got some CO2. We've got CO2.
Sats are coming
60%,
up.
70%. Heading up to 80 now. It's blood everywhere still. Still can't see anything.
start.
Yep.
For those who don't know me, my name is Mutua Mbuvi. I'm a medical officer at KNH, Accident Emergency Department. And as the speaker said, it's true. We make mistakes. Oh, I found out the difference. So an error, you cannot point it to a particular person, but a mistake is someone who's responsible.
Someone responsible, yes.
Yeah.
Good, thank you.
In terms of errors, like you gave your story, when you finish internship, then you come out, you know, MO. Yeah.
Daktari mkubwa.
Yes. And then for the first part of my MO career, I was at Avenue Hospital. So at Avenue, not so much of trauma or accidents and these things. We don't get much of emergency like there. Then I made the transition to KNH. So coming from an environment where you used to see patients of flu, back pain, such people. And then you come to KNH A&D, which is a special place. That's special.
Yes.
So I went to KNH A&D and I thought, you're a doctor, you have all the knowledge.
You're daktari mkubwa. Yes.
So we got this patient, came in, trauma, fell off. The motorcycle was hit, and she was a passenger at the back seat, so she was hit and she fell down. And she came, at the time when she came, saturations were around 75. So she came, put on oxygen, put in what you call a resuscitation A, which is for trauma patients, for surgical trauma patients. That's what we usually do, close observations and things like that. On that particular day, I was one who was covering the resuscitation phase. So I came, saw her, took her history, she was talking, you do your assessment and everything, did the trauma protocol, airway was secure, breathing, a bit of reduced airway on the left side, but you're like, we can, anyway, right now she's on oxygen, she's saturated at 95, so we're good.
Very good.
Center for the trauma series, x-rays, but so when they came back, I went through the x-rays, but since I had like 2 other patients in there, my mistake was that I went through them in a bit of a hurry. So the chest x-ray, just to put it on there, I looked at it.
No, you didn't make a mistake. You did what you normally do. Okay. Which that's what you do in the ED. I'm like, okay, yeah.
So I looked at them, the chest x-ray was like, no tracheal was out. And gave medication on the car. So I knew this patient was surgical ward, and they left. My shift ended. The next day I was coming back for an afternoon shift. I come back, I check into the resuscitation rooms to say hi to them, the people who are there. I'm looking at this bed and I'm thinking, why does this lady look familiar? That time she's looking familiar, but she has a chest tube, she's intubated. So I'm thinking, okay, what the hell happened? So I go back to the file. Go to the file, go to the file, go to the file. Then I'm beginning to see notes. I'm seeing the gen surge review. I don't know, rib fractures on rib 3, 4, 5. Pleural pneumothorax noted at this particular level. Cardiothoracic surgeon review, pneumothorax, blood, insert chest tube. Then I'm seeing the notes for the doctor who was there. Patient desaturated, decision made to intubate. What if patient intubated, chest tube inserted, looking for ICU bed. To tell you the truth, I was so shocked. Actually, because that day I was not covering the resuscitation, I was covering the medical side. I just walked out nicely. Went, started the medical side, and I started seeing patients. But for the rest of that day, as even the patients I was seeing at that time, I felt like I was doing them a disservice because my mind was
you're not there.
Yeah,
Yes.
You're here, you're trying to listen to them, but at the back of your mind, you're hitting yourself. How could I miss a thorax in a trauma patient? How?
Yes.
From that day, and I did exactly what that day did. I went home that night, I was not able to sleep. I was on Radiopedia. Show me chest x-rays with pneumothorax. Yes. Sorted. Just like, so this is what you look for. Okay, so this is what you see. Okay, so this is what you see. That's what I went through like an entire 2-3 days. Unfortunately, that patient died.
Yeah.
That became even worse now. Because I was like, okay, I am practically responsible for the death of this lady. She was a mom. Her baby was around 6 months old.
Yeah.
Okay, but at the back of your mind,
you know what exactly what happened.
An extra minute looking at that X-ray. If you had picked up that pneumothorax, that lady would have been alive.
It's good.
You never get a chance to talk about this.
We don't talk, yes, and that's a problem. And they're there, so thank you very much. All right, good. Another one? Yes.
I think I never had time to recover.
Yes.
First day, I reported to Kenyatta. No orientation.
Yes.
Sent to resuscitation. It was a habits. Maybe people have.
Drink party.
The worst thing is that the last Friday, nobody told me about the last Friday of the month. And the first Friday of the month.
Walevi wote.
The trauma patient. So, I remember night, I resuscitated 2 patients with more success. We got a trauma patient. Fast. I did the trauma series whenever I had questions.
Gotta fast.
And then the CT scan, all these other development comes back. There's head injury, knee fractures. And then I was called by the nurse. I told him, I go through these and advise us on the way forward. I told them, no, that gentleman is a trucker. Let me have some.
These are the worst.
Let me get done with these cases and then I'll come back.
To the drunkard.
Yes. Probably it's alcohol.
Yes.
Now, 10 minutes, barely 10 minutes, the bell was rung. We all rushed to the resuscitation
Yes.
room. Then I find a group of medical students. The nurses, everybody staring at me. We start resuscitation. The relatives are calling, they tell us to resuscitation. The nurses asked, do we really need to continue with the resuscitation? We stopped. The proper, the SLS.
The proper, yes, yeah.
Very well. The last week, it's normal. So we sat down, started writing
The notes.
summaries. The patient obviously started the character. And nobody tells me that you've done something wrong. Then after now, everybody now has left the room. The team leader of the nurse comes and tells me, I tell you, no, you killed that patient. I'm like, how did you kill the patient? Yet we are all there.
And you are there. Yes.
No, but this is the first day. Remember, this is the first day. I was so confused. I didn't know what to tell. Prior to this patient, I've already lost 2 critical patients.
On the same day.
Resuscitation. I'd given all my best. So I walk out, go through the ACLS, the ATLS, trying to find where the problem is. And the fact that the relatives were there, no, it was entirely done the best. They're very happy. The nurse told me what? To know where you left.
To bus, yes.
At the back of my mind, if I had attended to this patient and called the resident to review the patient, probably would have rescued this patient. But I said, you learning left.
Mlevi, yes.
For the next 2 months, I was traumatized. Every time I passed through resuscitation room, either A or B, I would have palpitations. And it really affected me.
It does,
To the point
yeah.
I requested not to be placed in resuscitation room for the next 4 months. And every time I go home, I think about the remarks, the relatives of the patient, the feedback they give. And you know, they normally write, so and so did well, the customer.
Okay.
And I got through it and I had a self, and I thought I was a failure. The next 4 months, I thought I was a failure. I don't deserve to do KNH. I should go back to Nanyuki. That's where
Things are stable. Yes.
Therefore, I'm supposed to be practicing the village doctor.
Yes.
Until I, with time, realized it's not. I had to observe how people go
You
about.
learn, yeah.
I learned, and I realized so many people make mistakes. Then that's the time I said to myself, well, you did your best. You need to put up a better spirit and know what you're doing at exactly academy.
Good, well done. And that's the thing, you know, how many of you rotated through the emergency department in your undergraduate training? So yes, so which part was this in your training that you were faced with a drunk trauma patient? Yet you've graduated, you have your degree, yes, you finished, and you're told this is your drunk trauma patient. Women's were ward patients, malaria, and that's the thing about emergency care and how emergency medicine even grew is because we have the most junior doctors in the system taking care of the sickest patients in the system. People who are fresh, green-eyed from school and come in and you're told, haya, shika mgonjwa. You have no clue. So, and that's the thing. It's not, that's what I'm saying, even from both cases, listening to them. It's not that it's your fault. It's you, this is the first time we are learning by experience. But unfortunately, our training experience involves mortalities, which is sad. But yes, and you can imagine how many patients have gone through the same process of the most junior doctor, and it's not the doctor, and I'd like to say it's not the doctor's fault because he was not trained, okay? And that's why we push for training of emergency care because we are not trained. You just are shown the best patient, the sickest, and told shika uyo. Yes. Now, and the problem is with the system is, as you say, the nurse will say, or someone will say, you killed the patient, but we move on. We move on, no lessons learned, no systematic changes. We don't review the cases. We all quietly sweep them under the rug. All your dead bodies are just hidden under a rug somewhere, and there's never really a reflection on what really happened, okay? And in fact, for my department, when I know we have, okay, now people are happy just reporting themselves, but when a doctor comes in and every single mortality is that doctor, it means only two things. What? Can you guys guess? Skills, let's hear skills, Knowledge, Any other one? I'm coming to this side because I want to hear what you guys have to say on this side. Anything else? Skills, knowledge? But you see, for emergency departments, it's not always like that. The doctor with the highest mortality rate is probably the bravest doctor who wants to see the sickest patients. Yes. Many people will run away. Just, avoid resuscitation room. That place is just bad. But yeah, so there are two aspects of it. It says that yes, there could be a knowledge and skill issue, but a good chance is the doctor who is seeing the sickest patients is the one with the highest mortality rate because he's or she is the bravest person to just go and try and stabilize his patients. So it's not always that if a doctor has high mortality rate, they're the worst doctors. It's just that probably they're the only ones who are brave enough to see the sickest patients. And that's what happened in the emergency departments. Initial reaction, if they're not in line, then all this can easily go south. And that's actually why a lot of the emergency care is based on protocols, because you don't have time to think. Sometimes you just don't have the time to think about it, and it's good when you're working through a protocol. And like the first case we watched here, in fact, that is what actually led to the development, the Vortex approach to a difficult airway, because of that similar case where people just went on a whole new tangent. All right, anyone else? Come on, we've had any female. Yes, hi, welcome.
My name is Peter.
Yes.
Okay, my name is Nadia.
It's fine, yes.
So during internship, I started with Oxfam. So during the end of one shift, like we just about to hand over. I was told the patient was having difficulty in breathing. She had just delivered maybe 18 hours. So first thing in the morning, I'm like, maybe she has pain. Then I think I was limited into thinking of only DVT.
P.
So I checked the signs of DVT, nothing. I asked her how long she's been coughing. She tells me she's been coughing a few days before she came. So honestly, I misdiagnosed her. But in my mind, I'm like, hey, no. So I called my second call. He's not picking up because you're not again.
Yes.
Next shift to come. So he doesn't pick up. I try calling the intern who's coming in because it was a weekend. I tell her, there's this patient. I'm not comfortable, but please see her. You know, and talk to them. Second call about it. I think the mistake I made was also I did not consult my consultant about this one. So unfortunately, because I diagnosed, sorry, when they came in, they were called for PPH. So you know, they wouldn't rush.
They went to sort the PPH out, yes.
They went to sort the PPH, so they saw the patient a bit late. So they were on the endoscopy, and called for transfer to ICU, Kenyatta, there were delays. So the next, on Monday, come back, I'm still not comfortable because I was so sure. So I go ask, what happened to the patient? I said, I was told that patient passed on, and they need him to be taken to care. It's been 4 years and they still.
You never forget. Yes,
Yeah.
you'll never forget. All right. Yes. I remember once those drunkards working. I swear. Let me tell you, you learn after that how to not categorize patients. Working in a very busy. You think Kenyatta is bad? I was working in emergency unit in Cape Town, and it's busy. And I'm in charge. I'm running the shift. I've got 2 junior docs with me. And it's just patient. It's one of those nights where it's triage survival here. So this ambulance rocks in, brings in this guy. He's already just like on his fours on the stretcher. And he's like, he was hit by a vehicle, he's drunk. He's just shouting all over the place. I'm like, okay, fine. Put him on the corner there, we'll deal with him. Yes. So they put him on the corner. And in the course of the night, he's just making noise. I'm like, yeah, we'll get to him. So of course, the thing is, the more just patients keep flowing in. Then in the morning, it's calm down, you're like, okay, let's do a round, see who's in the department. And we get to his bed, and he's dead. Yes. So, no one saw him, no one assessed him. He just lied on the bed. The ambulance put him on the hospital bed, and he just stayed there. And he died. You're like, then, so you're like, okay, so what killed this person? So just quick assessment, his pelvis, so we close the pelvis, and the pelvis just closes properly. So he had a pelvic fracture. So all that screaming and shouting was, yes, the highness, the pain, and his pelvic fracture. So he just bled out on the bed. And you're like this is, you're like, you're like, what? You're there, you're the one in charge of the shift. So you are the one in charge of all these patients, and you're like, this, how did we just miss this? Yes. And there are many factors. And after of course, we review the case, review the situation. And the ED, there are many factors that come into play. We'll actually watch a clip here about, who has watched the movie Sally? Good, you're a nice crowd. It's about human factors. And we'll probably just play that now. It's about, so quick brief. Sally, there's a plane that landed in the Hudson in the US. So pilot was flying and landed his plane in the Hudson. And of course, yes, people survived, everything went well, but he was called in for an inquiry because they're like, he made a mistake. Okay? He should not have, he had many options of airports. Why did he bother to why did he land the plane in the water? Yet all the simulation stuff shows that he should have been able to get to an airport. Okay, so I'll just leave it there. We watch the video. If we are working together to improve that, communicating more, sharing, and in fact, sharing your cases. Had this patient, I did this what happened, these are lessons learned, and everyone then learns from the cases. I think we'll be able to build us up an emergency care system that is at least safe for all of us working in it. All right, questions or comments? Yes.
Now, you're an emergency physician.
Yes.
What do you,
like how do you set up your day? How do you ensure that your department is moving in the right track? Like,
in what aspects? In what aspects?
Like in terms of you want to create harmony, you want to ensure there is no like how do you run your department?
So simply put, it all boils down to building a culture. So it's not something that you wake up one day and just say it works. Building a culture where everyone is has ownership of the department. Everyone feels that they belong in the department. Everyone is happy to contribute where there are changes, where things need to be done, and then making sure we're all on the same page. So, in fact, the genesis of our protocols was actually the emergency department, where we all needed to be reading from the same book, so that patients coming in are getting standardized care and not everyone's gut feeling. And you realize everyone's gut feeling is purely a lot of time from a point of ignorance. So trying to build that system where it's okay for you to Google, it's okay for you to read the protocols, it's okay for you to ask anyone, anything, anytime, and over time change the culture from blame game. So have, every time there's an incident, have a discussion around it, make them educational, not blame games, and help people, everyone pretty much learn from the case, and pretty much a happy, friendly, sharing environment, and not you did this, you did this, you did this. So yes, my staff has killed one too many patients, but we've discussed every case so they get less. It's picked up before it happens, so a lot of errors now are picked up even way before they happen, but it's because people are happy to report themselves and say, there was this patient, I missed this is what happened. So there's no blame game, and creating, as I said, a safe environment at the end of the day. And then now constantly, yes, so we have debriefings. We have, most of them end up being M&M sessions where if there's an error, let's have a discussion about it and just share, like, what are the errors, so it's not who did this, it's more of how do we prevent this from happening the next time, yes. And again, just people learning that sometimes we do make mistakes. We're only human. So it's not, say, there's no one, as they say, no one who comes to work every morning as a healthcare provider to do the wrong thing. No one wants to give the wrong dose of, those healthcare providers at Shalom Hospital did not wake up that morning coming to work to say they're coming to give 20 milligrams of morphine to a child. That was not their plan that day. Mistakes happen, and yes, if the bigger mistake is not learning from this, and also then making it bad people's problem and not looking at the whole picture. So it's a time thing that you build slowly by slowly, like what she's doing at Engineer Hospital. Same thing, monitor, start working together as a team, and once everyone has ownership of the department, once everyone has ownership of the whole process, then you're able to move together as one team. Yes.
My name is Victor, nursing student, currently in Mpisha. So I have a question of when like an emergency has occurred and you are called a code blue, but now here you meet with a doctor. Then when you inform the doctor about what is happening, the doctor tells you, too young to start handling this. Can you just go to the next doctor? How do you handle such a situation?
Again, culture. And it's probably not the right point where to start having that discussion. For you at the moment, a priority is to make sure the patient gets resuscitated. So if it means calling the next doctor, fine, call the next doctor. But at some point, you all need to have a discussion about this in terms of maybe the junior doctor needs to go for training, then they can be more comfortable. So it's not to say he did the wrong thing, but it's saying he can't respond. That was his position, but that point is not the point where you're having. If we are working together to improve that, communicating more, sharing, and in fact, sharing your cases. I had this patient, I did this what happened, these are lessons learned, and everyone then learns from the cases. And I think we'll be able to build up an emergency care system that is at least safe for all of us working in it. All right, questions or comments? Yes.
Now, you're an emergency physician.
Yes.
What do you, like how do you set up your day? How do you ensure that your department is moving in the right track? Like,
In what aspects? In what aspects?
like in terms of you want to create harmony, you want to ensure there is no like how do you run your department?
So simply put, it all boils down to building a culture. So it's not something that you wake up one day and just say it works. Building a culture where everyone is has ownership of the department. Everyone feels that they belong in the department. Everyone is happy to contribute where there are changes, where things need to be done, and then making sure we're all on the same page. So, in fact, the genesis of our protocols was actually the emergency department, where we all needed to be reading from the same book, so that patients coming in are getting standardized care and not everyone's gut feeling. And you realize everyone's gut feeling is purely a lot of time from a point of ignorance. So trying to build that system where it's okay for you to Google, it's okay for you to read the protocols, it's okay for you to ask anyone, anything, anytime, and over time change the culture from blame game. So have, every time there's an incident, have a discussion around it, make them educational, not blame games, and help people, everyone pretty much learn from the case, and pretty much a happy, friendly, sharing environment, and not you did this, you did this, you did this. So yes, my staff has killed one too many patients, but we've discussed every case so they get less. It's picked up before it happens. So a lot of errors now are picked up even way before they happen, but it's because people are happy to report themselves and say, there was this patient, I missed this, this is what happened. So there's no blame game, and getting, as I said, a safe environment at the end of the day. And then now constantly, yes. So we have debriefings. We have, most of them end up being M&M sessions where if there's an error, let's have a discussion about it and just share, like, what are the errors, so it's not who did this, it's more of how do we prevent this from happening the next time, yes. And again, just people learning that sometimes we do make mistakes. We're only human. So it's not, say, there's no one, as I say, no one who comes to work every morning as a healthcare provider to do the wrong thing. No one wants to give the wrong dose of, those healthcare providers at Shalom Hospital did not wake up that morning coming to work to say they're coming to give 20 milligrams of morphine to a child. That was not their plan that day. Mistakes happen, and yes, if the bigger mistake is not learning from this, and also then making it that people's problem and not looking at the whole picture. So it's a time thing that you build slowly by slowly, like what she's doing at Engineer Hospital. Same thing, monitor, start working together as a team, and once everyone has ownership of the department, once everyone has ownership of the whole process, then you're able to move together as one team. Yes, yes.
My name is Victor, nursing student, currently in Mpisha. So I have a question of when like an emergency has occurred and you are called blue, but now here you meet with a doctor. Then when you inform the doctor about what is happening, the doctor tells you, too young to start handling this. Can you just go to the next doctor? How do you handle such a situation?
Again, culture. And it's probably not the right point where to start having that discussion. For you at the moment, a priority is to make sure the patient gets resuscitated. So if it means calling the next doctor, fine, call the next doctor. But at some point, you all need to have a discussion about this in terms of maybe the junior doctor needs to go for training, then they can be more comfortable. So it's not to say he did the wrong thing, but it's saying he can't respond. That was his position, but that point is not the point where you're having this discussion. Okay, priority is, again, the patient and not the doctor. And then maybe at a different forum, having that discussion and seeing maybe the junior doctor needs to be trained. And then that way they'll be capable to, they'll be happy to respond when you call them. So it's still, yes, priority always the patient, but again, then now having open discussions about such situations. Yes. Any other comments, questions? Yes.
Not a question, but in reference to what she was asking. Like where I'm from, we usually have a mortality review.
Yes.
Anytime we have a patient who dies in our clinic, NSF.
Yeah.
And we also have the protocols.
Yes.
We have to admit and we also have that. And also documentation is so important. Because when there's a mortality review, someone will be documenting.
Yes.
If there is a mortality review, that's what they pull out. Things such as that. And
A common mistake we do, and this happens across, we only look at the deaths, okay? We only do mortality reviews. We never have reviews about patients who was a near miss, patient who was a difficult case and we didn't manage it optimally, okay? We never, for example, the patient, just use this example, the patient who had anaphylaxis. That's a good case to actually have a discussion around. Yeah, the patient's alive and they're fine, but why didn't we pick this up initially? Why was there a delay in us giving adrenaline? Why were we? So looking at, and because eventually people get tired of coming to talk about dead people, okay? And that's why your M&Ms end up just being very boring sessions, because only time we meet is you should meet to discuss those who survived, okay? Those who are challenging but survived. So discuss more of the ones you save and the ones who would have been managed better, and less of the dead ones also need to be discussed, but they should not be the majority. You should never just be coming to have mortality meetings. You'll be having morbidity meetings where patient came in, CT was delayed for some reason, patient ended up intubated. So where things didn't go as they should be, and that helps you review your whole system in a safe way because no one died, but also then prevents all your mortality meetings. Yes. Mm-hmm. Yes, you should have a lot of those. Yes. Good. Yes. Reviewing the documentation, and it's not a blame session. All right. Good. Any other questions, comments?
I think take home for today.
Yes.
Like you said, taking responsibility, taking ownership of the air. Once you destroy the silos of bacteria.
Those ones don't exist. Yes.
When we destroy those silos and everyone takes that responsibility of the AMD, I think we'll actually achieve a lot.
You'll achieve more.
Mortalities reduced.
Yes.
Yeah, then evidence can be more.
Mobility. You should actually have mobility meetings to discuss the other cases that you saw. Yes. Get a hand up. Yeah.
As nurses, there's always this support system we have, because sometimes we are so. But for these new doctors, like for this case, his name Kenyatta, he's placed in resuscitation room. I think they need to be a support system, especially when they come to these high-end hospitals. They find a hard time.
But you are the support system. Yes. You see, that's the thing. Yes. Yes.
To the doctors, like, he'll be alone.
Yeah, but he has you.
Yes, I don't refuse.
Yes.
There are some things I can't do.
No.
Say,
yes.
I'm not allowed to intubate something of the sort.
Doesn't mean you can't.
Yes, I can. Some places you're not allowed.
Yes.
As a nurse. So you find that we had a doctor who came in. He was very new from, I think it was Moran. Patient came, was critical, needed intubation.
Shocker.
So he was asked by a senior nurse, like there was an emergency nurse. So I was asked, doctor, will you intubate? So the doctor started looking at
those are test questions, first of all. Why are you asking test questions?
No, so wherever he was, he admitted he had never intubated, like he had never seen such things. And actually he was placed at the E1 doctor. You see, like for us nurses, we can just come doing this, tell me, but for the doctors sometimes they're like, I'm not the E1 today.
You see, we need to break, that's the thing about the ED. We need to break those. The ED, there's no room for silos. There is no doctor backs orders, nurse does. Okay? A lot of the emergency nurses can do almost actually everything the doctor can do. There's a very thin line, yes, that the nurse, and the nurses know normally, especially an experienced ER nurse, has been there, has seen all these patients. So we need to work together as a team versus working as individuals and standing back and saying, let's just see how this junior doctor sinks in death here. Yes, which is also that I know it happens where we blame the nurses for this, because we have senior nurses, and for us we take our nurses to the laundry for that, because you are a senior nurse, you know this system, you know how this patient is supposed to be managed, but you actually just watch the patient die. Like, how now? Like, it's not just because the doctor was junior and didn't know what he's doing. For us, we blame you, the nurse, and less on the doctor, because you are a team. You're not individuals. You're a team. So if that patient needed to be intubated, you as the emergency nurse should have figured that part out. Yes, the doctor clearly he's still trying to survive, breathe. Yes. So it's removing that whole culture of doctor, nurse, and more working as a team. Remember, at the end of the day, it's about the patient. It's not about us, our egos, our failings. It's about the patient. Good. All right, last one. Yes.
Thank you.
Yes.
My name is Kasim Sharif. I work in Wajir County.
Ah, good. Uh-huh.
As a county hospital called Grift.
Yeah, yes, Grift too. I remember mapping it, yes. Yes.
So I think we talk about a lot. Thank you for organizing the talk. I would like to ask a few questions starting with training. So I would like to ask how this training is organized. Because I was not invited. I was invited for a lot of others, but I've not had it.
Speak to Emily after that. Uh-huh.
The other one, I've seen while I work at that hospital, there was a lot of focus on maternal death.
Yes.
We do a lot of audit. We are provided with a lot of analysis. We are told our mistake, but I've not seen the general patient.
Yes.
All the patients. So is there any plan
to build that?
The existing one that we can learn our mistake, then there's a regular review that's done.
So for the maternal, this is because of the whole, it's a policy issue. A country's healthcare system is judged by its maternal mortality, under 5 mortality, birth rates, death rates, things like that. So they never really look at all the other people. So you as an adult, you just die peke yako. Yes. Okay, but the truth of it is we have way more people dying from emergency care situations, and adults and children, and those maternal and children mortalities. And the focus, of course, is on if a mother dies, in fact, the hospital almost shut down. Yes. Yet you've killed 100 regular adult patients who would have been saved, but one mother dies, your hospital inafungwa. Yes. So it's a culture change. So it's not necessarily, that's how the system is built. But even within your own emergency departments, you can start looking at this, have these discussions. Don't just say mgonjwa alikuwa. Never accept that whole alikuwa mgonjwa sana. That is something we need to move away from.
I think we have to do something about a culture, a piece of the culture of medicine that has to change. And I think it starts with one physician, and that's me. And maybe I've been around long enough that I can afford to give away some of my false prestige to be able to do that. Before I actually begin the meat of my talk, let's begin with a bit of baseball. Hey, why not? You know, we're near the end. We're getting close to the World Series, right? We all love baseball, don't we? Baseball is filled with some amazing statistics, and you know, there's hundreds of them. Moneyball's about to come out, and it's all about statistics and using statistics to build a great baseball team. I'm going to focus on one stat that I hope a lot of you have heard of. It's called batting average. So we talk about a 300, a batter who bats 300. That means that ball player batted safely, hit safely 3 times out of 10 at bats. That means, you know, hit the ball into the outfield, it drops, it didn't get caught, and whoever tried to throw to first base didn't get there in time, and the runner was safe. 3 times out of 10. Do you know what they call a 300 hitter in Major League Baseball? Good. Really good. You know, maybe an all-star. Do you know what they call a 400 baseball hitter? That's somebody who hit, by the way, 4 times safely out of every 10. Legendary. As in Ted Williams legendary, the last Major League Baseball player to hit over 400 during a regular season. Now let's take this back into my world of medicine, where I'm a lot more comfortable, or perhaps a bit less comfortable, after what I'm going to talk to you about. Suppose you have appendicitis, and you're referred to a surgeon who's batting 400 on appendectomies. Somehow this isn't working out, is it? Now, suppose you live in a certain part of a certain remote place and you have a loved one who has blockages in 2 coronary arteries. And your family doctor refers that loved one to a cardiologist who is batting 200 on angioplasties. But, you know what? She's doing a lot better this year. She's on the comeback trail and she's hitting 257. Somehow this isn't working, but I'm going to ask you a question. What do you think a batting average for a cardiac surgeon or a nurse practitioner or an orthopedic surgeon, an OBGYN, a paramedic is supposed to be? 1,000. Very good. Okay. Now, the truth of the matter is nobody knows in all of medicine what a good surgeon or physician or paramedic is supposed to bat. What we do, though, is we send each one of them, including myself, out into the world with the admonition, be perfect, never, ever, ever make a mistake, but you worry about the details, about how that's going to happen. And that was the message that I absorbed when I was in med school. I was an obsessive-compulsive student. In high school, a classmate once said that Brian Goldman would study for a blood test. And so I did. And I studied in my little garret at the nurse's residence at Toronto General Hospital, not far from here, and I memorized everything. I memorized in my anatomy class the origins and insertions of every muscle, every branch of every artery that came off the aorta, differential diagnoses, obscure and common. I even knew the differential diagnosis and how to classify renal tubular acidosis. And all the while I was amassing more and more knowledge, and I did well. I graduated with honors, cum laude. And I came out of medical school with the impression that if I memorized everything and knew everything, or as much as possible, as close to everything as possible, that it would immunize me against making mistakes. And it worked for a while, until I met Mrs. Drucker. I was a resident at a teaching hospital here in Toronto when Mrs. Drucker was brought to the emergency department at the hospital where I was working. At the time, I was assigned to the cardiology service on cardiology rotation. And it was my job when the emergency staff called for a cardiology consult to see that patient in emerge and to report back to my attending. And I saw Mrs. Drucker, and she was breathless, and when I listened to her, she was making a wheezy sound, and when I listened to her chest with a stethoscope, I could hear crackly sounds on both sides that told me that she was in congestive heart failure. This is a condition in which the heart fails, and instead of being able to pump all the blood forward, some of the blood backs up into the lungs fill up with blood, and that's why you have shortness of breath. And that wasn't a difficult diagnosis to make. I made it, and I set to work treating her. I gave her aspirin, I gave her medications to relieve the strain on her heart, I gave her medications that we call diuretics, water pills, to get her to pee out the excess fluid. And over the course of the next hour and a half or two, she started to feel better. And I felt really good. And that's when I made my first mistake. I sent her home. Actually, I made 2 more mistakes. I sent her home without speaking to my attending. I didn't pick up the phone and do what I was supposed to do, which is to call my attending and run the story by him so he would have a chance to see her for himself. And he knew her. He would have been able to furnish additional information about her. Maybe I did it for a good reason, you know. Maybe I didn't want to be a high-maintenance resident. Maybe I wanted to be so successful and so able to take responsibility that I would do so, and I would be able to take care of my attending's patients without even having to contact him. The second mistake that I made was worse. In sending her home, I disregarded a little voice deep down inside that was trying to tell me, Goldman, not a good idea. Don't do this. In fact, so lacking in confidence was I that I actually asked the nurse who was looking after Mrs. Drucker, do you think it's okay if she goes home? And the nurse thought about it and said, very matter-of-factly, yeah, I think she'll do okay. I can remember that like it was yesterday. And so I signed the discharge papers, and an ambulance came, paramedics came to take her home. And I went back to my work on the wards. All the rest of that day, that afternoon, I had this kind of gnawing feeling inside my stomach. But I carried on with my work, and at the end of the day, I packed up to leave the hospital and walked to the parking lot to take my car and drive home, when I did something that I don't usually do. I walked through the emergency department on my way home. And it was there that another nurse, not the nurse who was looking after Mrs. Drucker before, but another nurse said 3 words to me that are the 3 words that most emergency physicians I know dread. Others in medicine dread them as well, but there's something particular about emergency medicine because we see patients so fleetingly. The 3 words are, do you remember? Do you remember that patient you sent home? The other nurse asked matter-of-factly. Well, she's back, in just that tone of voice. Well, she was back all right. She was back in near death. About an hour after she had arrived home, after I'd sent her home, she collapsed. And her family called 911 and the paramedics brought her back to the emergency department where she had a blood pressure of 50, which is in severe shock. And she was barely breathing and she was blue. And the emerg staff pulled out all the stops. They gave her medications to raise her blood pressure. They put her on a ventilator. And, you know, I was shocked and shaken to the core. And I went through this roller coaster because after they stabilized her, she went to the intensive care unit, and I hoped against hope that she would recover. And over the next 2 or 3 days, it was clear that she was never going to wake up. She had irreversible brain damage. And the family gathered, and over the course of the next 8 or 9 days, they resigned themselves to what was happening. At about the 9-day mark, they let her go. Mrs. Drucker, a wife, a mother, and a grandmother. They say you never forget the names of those who die, and that was my first time to be acquainted with that. Over the next few weeks, I beat myself up. And I experienced for the first time the unhealthy shame that exists in our culture of medicine, where I felt alone, isolated, not feeling the healthy kind of shame that you feel, because you can't talk about it with your colleagues. You know that healthy kind when you betray a secret that a best friend made you promise never to reveal, and you get busted, and then your best friend confronts you, and you have terrible discussions, but at the end of it all, that sick feeling guides you, and you say, you know, I'll never make that mistake again, and you make amends, and you never make that mistake again. That's the kind of shame that is a teacher. The unhealthy shame I'm talking about is the one that makes you so sick inside. It is the one that says, not that what you did was bad, but that you were bad. And it was what I was feeling. And, you know, it wasn't because of my attending. He was a doll. He talked to the family, and I'm quite sure he smoothed things over and made sure that I didn't get sued. And I kept asking myself these questions. Why didn't I ask my attending? Why did I send her home? And then at my worst moments, why did I make such a stupid mistake? And why did I go into medicine? Slowly but surely, it lifted. I began to feel a bit better. And you know, on a cloudy day, there was a crack in the clouds and the sun started to come out, and I wondered, you know, maybe I could feel better again. And I made myself a bargain, you know, that if only I redoubled my efforts to be perfect and never make another mistake again, please make the voices stop. And they did. And I went back to work. And then it happened again. 2 years later, I was an attending in the emergency department at a community hospital just north of Toronto, and I saw a 25-year-old man with a sore throat. It was busy. I was in a bit of a hurry. He kept pointing here. I looked at his throat. It was a little bit pink, and I gave him a prescription for penicillin and sent him on his way. And even as he was walking out the door, he was still sort of pointing to his throat. And 2 days later, I came to do my next emergency shift, and that's when my chief asked to speak to me quietly in her office, and she said the 3 words, do you remember? Do you remember that patient you saw with the sore throat? Well, it turns out he didn't have a strep throat. He had a potentially life-threatening condition called epiglottitis. You can Google it, but it's an infection not of the throat, but of the upper airway, and it can actually cause the airway to close. And, you know, fortunately, he didn't die. He was placed on intravenous antibiotics, and he recovered after a few days. And I went through the same period of shame and recriminations and felt cleansed and went back to work until it happened again and again and again. Twice in one emergency shift, I missed appendicitis. Now that takes some doing. especially when you work in a hospital that at the time saw about 14 people at night. Now, in both cases, you know, I didn't send them home, and I don't think there was any gap in their care. One I thought had a kidney stone. I ordered a kidney x-ray. When it turned out to be normal, my colleague who was doing a reassessment of the patient noticed some tenderness in the right lower quadrant and called the surgeons. The other one had a lot of diarrhea. I ordered some fluids to rehydrate him and asked my colleague to reassess him, and he did. And when he noticed some tenderness in the right lower quadrant, called the surgeon. So in both cases, they had their operations and they did okay. But each time, they were gnawing at me, eating at me. And I'd like to be able to say to you that my worst mistakes only happened in the first 5 years of practice, as many of my colleagues say, which is total BS. Some of my doozies have been in the last 5 years. Alone, ashamed, and unsupported. Here's the problem. If I can't come clean and talk about my mistakes, if I can't find the still small voice that tells me what really happened, how can I share it with my colleagues? How can I teach them about what I did so that they don't do the same thing? If I were to walk into a room, like right now, I have no idea what you think of me. When was the last time you heard about somebody talk about failure after failure after failure? Oh yeah, you go to a cocktail party and you might hear about some other doctor, but you're not going to hear somebody talking about their own mistakes. If I were to walk into a room filled with my colleagues and ask for their support right now and start to tell what I've just told you right now, I probably wouldn't get through 2 of those stories before they would start to get really uncomfortable. Somebody would crack a joke, they'd change the subject, and we would move on. And in fact, if I knew, and my colleagues knew, that one of my orthopedic colleagues took off the wrong leg in my hospital, believe me, I'd have trouble making eye contact with that person. That's the system that we have. It's a complete denial of mistakes. It's a system in which there are 2 kinds of physicians. Those who make mistakes and those who don't. Those who can't handle sleep deprivation and those who can. Those who have lousy outcomes and those who have great outcomes. And it's almost like an immunological reaction, like the antibodies begin to attack that person. And we have this idea that if we drive the people who make mistakes out of medicine, what will we be left with but a safe system? But there are 2 problems with that. In my 20 years or so of medical broadcasting and journalism, I've made a personal study of medical malpractice and medical errors, and to learn everything I can from one of the first articles I wrote for the Toronto Star to my show White Coat Black Art. And what I've learned is that errors are absolutely ubiquitous. We work in a system where errors happen every day, where 1 in 10 medications are either the wrong medication given in hospital or at the wrong dosage, where hospital-acquired infections are getting more and more numerous, causing havoc and death. In this country, as many as 24,000 Canadians die of preventable medical errors. In the United States, the Institute of Medicine pegged it at 100,000. In both cases, these are gross underestimates because we really aren't ferreting out the problem as we should. And here's the thing. In a hospital system where medical knowledge is doubling every 2 or 3 years, we can't keep up with it. Sleep deprivation is absolutely pervasive. We can't get rid of it. We have our cognitive biases, so that I can take a perfect history on a patient with chest pain, now take the same patient with chest pain, make them moist and garrulous and put a little bit of alcohol in their breath, and suddenly my history is laced with contempt. I don't take the same history. I'm not a robot. I don't do things the same way each time, and my patients aren't cars. They don't tell me their symptoms in the same way each time. Given all of that, mistakes are inevitable. So if you take the system as I was taught and weed out all the error-prone health professionals, well, there won't be anybody left. And you know that business about people not wanting to talk about their worst cases? On my show on White Coat Black Art, I made it a habit of saying, here's my worst mistake. I would say to everybody from paramedics to the chief of cardiac surgery, here's my worst mistake, blah, 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 blah. What about yours? And I would point the microphone towards them. and their pupils would dilate and they would recoil. Then they would look down and swallow hard and start to tell me their stories. They want to tell their stories. They want to share their stories. They want to be able to say, look, don't make the same mistake I did. What they need is an environment to be able to do that. What they need is a redefined medical culture. And it starts with one physician at a time. The redefined physician is human, knows she's human, accepts it, isn't proud of making mistakes, but strives to learn one thing from what happened that she can teach to somebody else. She shares her experience with others. She's supportive when other people talk about their mistakes. And she points out other people's mistakes, not in a gotcha way, but in a loving, supportive way, so that everybody can benefit. And she works in a culture of medicine that acknowledges that human beings run the system, and when human beings run the system, they will make mistakes from time to time. So the system is evolving to create backups that make it easier to detect those mistakes that humans inevitably make, and also fosters in a loving, supportive way places where everybody who is observing in the healthcare system can actually point out things that could be potential mistakes and is rewarded for doing so, and especially people like me, when we do make mistakes, we're rewarded for coming clean. My name is Brian Goldman. I am a redefined physician. I'm human. I make mistakes. I'm sorry about that. But I strive to learn one thing that I can pass on to other people. I still don't know what you think of me, but I can live with that. And let me close with 3 words of my own. I do remember.
All of us come here to do good work every day.
We all got into healthcare to do the best we can for patients.
And you have to remember, when those patients come into UHN, they're at their most vulnerable state.
We put our trust in the people within this hospital, and so we expect to get in and out of here in one piece.
But we're human and we make errors.
And it may be because people are working too fast.
Sometimes the supports are not there.
And sometimes even the system that we have actually set up a possibility for humans to make error.
It could be a lighting issue that they didn't read a label properly. It could be fatigue. It could be a distraction. The best people make mistakes.
When an error happened, every one of us who is directly or indirectly involved, we don't feel good about it.
I can remember that event like it was yesterday.
It made me feel horrible.
I really almost killed someone.
I know exactly the pain, the shame, the embarrassment that I felt.
Well, I hate myself.
I thought I was frightened, scared for my life.
It was transformational for me in many ways and crystallized my own passion for safety.
We can no longer turn a blind eye to some of the safety issues that are happening within our hospitals.
And why now is because I don't think it's getting better.
And there's no question that errors can be prevented.
UHN has the opportunity to lead in this regard.
We don't want our patients nor our staff to be harmed by preventable errors.
Caring safely means being able to prevent harm.
It means embracing safety as a core value in our organization.
Where all our staff feel that they are all safety leaders.
Wanting to provide a safe environment for myself as well as my co-workers.
Without healthy working staff, we can't have healthy patients.
Because ultimately, if it's bad for the patient, it's really bad for our staff.
There's certain never events that really shouldn't occur in hospitals that we can actually prevent.
But there are going to be things that happen that maybe we haven't identified.
We have to state a goal of 0 safety events, getting to 0.
And we wouldn't be doing our patients justice if we were okay with some incidents happening.
We can see from the experience of other organizations that this type of goal is achievable.
And there are hospitals that have turned the tide and actually decreased their serious safety events.
The objective is when a staff member A makes a mistake, how do we build in a redundancy? How do we build in a safety net so when that error happens, either your peer catches it or we have support system that alerts the staff that something wrong is going on?
Every time a human makes a mistake, we need to look at what was it they were doing and was there a system issue involved that we can correct or mitigate happening again.
And fixing them for the long term.
We need to recognize that many errors inside medicine today occur as a result of communication gaps and as a result of cultural things such as fear of reporting.
Caring safely means that we have to change the culture that we were brought up in,
which is described by many people as shame and blame.
Then we need an environment where when that person notices something, they feel empowered to actually question that and to raise that as a concern. And then the response to that is, thank you very much.
It's about focusing on what we could do better, not who did what wrong.
Because when you speak up, what you're trying to do is prevent that person from making an error.
When it comes to safety, there's no room for ego. It's all about the patient.
Success is very much where people have a comfortable environment that issues can be brought to the fore.
The trick is not to do it again. The trick is to actually learn from it and not keep it to yourself, but share it with others so that somebody else doesn't make the same mistake.
We should reward people who report incidents.
If somebody raises a safety issue in one of the huddles, we recognize them often with a good catch letter.
We want to keep our coworkers safe. We want to keep everybody working in all the capacities in the hospital safe.
We want to ensure that our patients and our staff are safe every day.
We all have the power to make a difference.
Be part of the solutions.
And help us design a better environment for caring for patients.
We're committed to caring safely because it's the right thing to do.
It's time to act.
You're responsible for people's lives.
Caring safely is with us and it will be with UHN forever.